Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. I've really been looking forward to the conversation today. I'm honored to be joined by Lisa Wauters, a research SLP, a doctoral candidate, and an expert in the area of primary progressive aphasia. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome, Lisa. So great to have you here. Can you get us started by sharing a little bit more about yourself?
Yeah, thanks, Sarah. It's really great to be here. Yeah, so I'm a doctoral candidate at the University of Texas at Austin, and I work in the aphasia research and treatment lab under the mentorship of Dr. Maya Henry. I'm also a per diem research SLP working remotely at the Memory and Aging Center at the University of California, San Francisco. I've been an SLP since 2016, and I worked in the field for a while, both in a private clinic and in home health, and then was hired back to work full-time as a research SLP for the lab. After a couple of years of working as a full-time research SLP, I decided to apply for doctoral studies with Dr. Henry, and so staying in that lab. And so our primary focus at the lab right now currently is developing effective treatment approaches for primary progressive aphasia. And so since 2018, I have been working on a daily basis with people who have PPA. And I have also worked as a co-chair for the PPA task force that's run by the National Aphasia Association. And I am a facilitator for the PPA chats at the NAA as well.
Fantastic. I'm really looking forward to hearing about the research you're up to in your lab. Let's go ahead and just start about talking about the population, people with primary progressive aphasia. This is a really special population, and I'd love to hear what initially attracted you to working with this population and maybe even how your clinical interest has evolved over time.
Yeah, sure. So first, just want to give some time to give a brief definition of what we mean by primary progressive aphasia, or often shortened to PPA. So PPA is a clinical syndrome in which language and or speech demonstrate progressive decline over time. There are three main variants of PPA that are recognized, though many people with PPA may not fit neatly into one of the main variants, and there's some research work looking into that. But for the three main variants, there's a semantic variant of PPA, and that's characterized by impaired naming and word comprehension, as well as eventual loss of object knowledge. The logopenic variant of PPA is characterized by impaired word retrieval and difficulty with repetition. And then that's alongside relatively spared word comprehension and semantic knowledge as compared to the semantic variant. And finally, there's the non-fluent agrammatic variant of PPA, which is characterized by apraxia of speech and agrammatism, with some people experiencing more of an isolated apraxia of speech. And that sometimes or often is referred to as primary progressive apraxia of speech. Frontotemporal degeneration, or FTD, and Alzheimer's disease are the two most common diseases that underlie PPA. The communication impairment is prominent and relatively isolated in the early to middle stages of the disease, but with progression, oftentimes other domains such as memory, personality and behavior, or gross motor skills could be affected. So every course is a little different. And just to give an idea of some of the abbreviations I'll be using moving forward. So to refer to semantic variant PPA, that's SVPPA. Logopenic is LVPPA. And for the non-fluent agrammatic, NFV PPA.
We got to have all the letters in there, don't we?
And it can get confusing. So I just wanted to point that out.
Thank you.
So in terms of how I got interested in this population, even before meeting my current advisor, Dr. Henry, I recall that I had chosen PPA as a research paper topic in one of my leveling courses. So when I was taking classes to prepare for applying for a master's degree, I was really interested in that topic of progressive communication impairment and in particular, whether we could capitalize on neuroplasticity to help people kind of maintain their current status for longer. So I think in my research paper, I focused a lot on a technique called spaced retrieval. But in any case, I was just generally interested in that topic. But then as a master's student, so fast forwarding a couple of years when I did meet Dr. Henry and did a clinical research rotation in her lab, I was just really impressed by the types of treatment she was doing with people who have PPA, as well as the outcomes that people were experiencing. I initially worked with 2 individuals during that rotation, doing a type of lexical retrieval treatment, and they were both so positive about their experience. They really felt like the treatment was helping them. And so I would say in the early years of working in the lab, we really had 2 main treatments that we were focusing on. The first is that lexical retrieval treatment, and that's based on the lexical retrieval cascade that was written about by Paige Beeson at the University of Arizona. And basically in this treatment, we pre-select words to work on. People send us photos of items that are important to them. And we choose items from those photos, sometimes supplementing a little bit. And we go through a series of activities during each of our therapy sessions that are meant to help a person self-cue themselves to retrieve a word. We first engage in semantic feature analysis and ask them to describe the item to us. Then we ask them to try and write the word, think about whether they can visualize any bits of the orthography. And finally, we try to think about whether any sounds of the word are coming to them. At this point, if they're unable to retrieve the word, we provide them with the initial phoneme of the word. And if that doesn't help, then we provide them with the full word to read out loud. Over the years, we've added some different components into a second version of this approach as well. So we now ask participants to think about words in the same category as the item in a sort of generative naming task. We have them describe a complex picture with the target item embedded, and we have them generate sentences with the target word that they could see themselves saying in their everyday life. So our goal with these new activities is to hopefully increase that generalization to everyday life.
Awesome. Let me ask a quick question. So that was the lexical retrieval treatment. So when you start using the different pictures, are clients not able to name the pictures, or are they still able to, and you're kind of working on like maintaining the skills?
Yeah, that's a great question. With the great majority of our participants, we are actually looking for words that they cannot name consistently. So we kind of show them the picture on 3 occasions prior to beginning treatment, and we choose those items that they miss 2 out of 3 times, at least 2 out of 3 times. That being said, the 2 people that I did work with in my initial research rotation with the lab were people that we were doing more of a prophylactic treatment with. So many of the words they worked on, we were actually doing that exact thing. So they were words that the participants could think of more consistently. And we were hoping to just reinforce that and to help them maintain. Yeah. So I think both are valid approaches.
Okay. Awesome.
All right. And then the second treatment that we focused on, or that we especially with our last 2 grants, is a script training protocol that we call video implemented script training for aphasia. And this combines script training, which is, of course, an approach that's been around for a long time, with a newer type of practice called speech entrainment that has been studied by Julius Fredrickson's group out of the University of South Carolina. And in that type of practice, the person engages in independent practice to produce their script in unison with a video of a mouth model producing the script. So it's literally just a video of like the lower half of our mouth model's face. And our mouth models are trained in over articulation. So the visual cues are really salient there.
Is it just the actual mouth moving, no sound?
Oh, it is. It's a video and audio model.
The audio. Okay, cool.
Yeah. So we think there's something really powerful about having a visual and an auditory model to match their own articulatory movements with. So they're speaking in unison at the same time. And they do that practice. We tell them to aim for 30 minutes a day. And then we meet for 2 therapy sessions every week. And we do a variety of activities like memorization exercises, targeted articulation practice, practice with using the scripts or parts of the scripts conversationally. Over the years, we've also added in a new component to the version of the treatment we do now, wherein the speech rate of the video is increased by 10% as they memorize and can intelligibly produce the scripts. So many of our participants are mildly impacted and they want to be able to speak faster and more smoothly. So they really appreciate being able to increase the rate that they're practicing.
Awesome.
And so I would say that we've seen excellent response to these therapies in our cohorts. Our participants get better at the things we train them on. And to some extent, we see evidence of generalization to untrained material as well, though it's a more modest effect and varies from participant to participant. There's something that we're trying out. The generalization, measuring that is something we're trying out new methods for. So we want to measure generalization in a way where we can capture better what our participants are telling us, because we do hear over and over from many of them how helpful they consider the treatments to have been. We give them these post-treatment surveys where we ask them about how much better they perceive themselves to be doing on a variety of communication skills. And these responses are overwhelmingly positive. So people generally, not 100%, but like the majority of people do perceive themselves as having improved. And care partners' responses on the surveys are also on the whole very positive. So they perceive their partners to have improved as well.
Very cool. Do you feel like for both of those treatments, the lexical retrieval, the script training with the video model, like, are you recommending the everyday SLP to like kind of start getting into that at this point if they haven't already?
Yeah, so I think that they're both very doable in the clinical world. I know, and of course that depends on your evaluation of each specific patient and kind of whether you think it's an appropriate treatment approach. So that's a good disclaimer to put out there. But for those that do seem to be good candidates for something like this, I know for the script training, getting those videos or filming the videos might seem like a barrier, but I have implemented that clinically previously. And what I would do was, have turn script development into sort of a therapeutic process. So not just like doing that outside of the session, but have it be very collaborative with the patient. And then I would, it would just take a very short time to just film the 1 minute long script of my own mouth. I would use my own mouth as the mouth model.
That's another barrier people have to get over. Like, you're going to use your own mouth as a video. That's a little hard when you've never done that before.
It sure is. Yeah, I definitely understand that. But yeah, I guess there might be other options for if you do have perhaps a colleague at your same clinic who's under the same sort of HIPAA agreement that's willing to do it. But it's cool. Definitely perhaps something that not many therapists feel comfortable doing, but once maybe you dip your toe in and that and get used to it, maybe it's a little easier. Yeah.
That's awesome. Well, thanks. So we already kind of have two treatment options. And I also wanted to talk about you were the first author on a recent systematic review on treatment for PPA. So just thinking about that article and the work you put in, can you just give us some of the highlights or the most important takeaways from that research?
Sure, yeah. So just to give some background, PPA has been identified starting as early as the 1980s by Dr. Marcel Mesulem. And some researchers had even published treatment cases as early as the mid-90s, early to mid-90s. Even though at that time we didn't have consensus over what the syndrome was, what to call it. The consensus diagnostic criteria for PPA were published by Dr. Gorno Tempini and colleagues, including Dr. Mesulem, in 2011. And when that happened, the amount of research focused on PPA treatment really proliferated. There had been a previous systematic review of speech-language treatment in PPA that was published by Dr. Karthri Goulart and colleagues in 2013. But of course, after 2011, that was just, so many people were publishing.
Review. Okay, awesome.
Yeah. And so there was a writing group convened by the Neurologic Communication Disorders and Sciences to kind of look into updating the evidence. And my advisor, Dr. Henry, was the chair of that group, and she recruited me to work in it. And over time, I kind of took the lead on the project.
Thank you.
Yeah, for sure.
From all of us.
Systematic search of the literature through May of 2021. It takes a couple years for projects to be published after you do the search. We identified 103 studies that examined speech-language treatment for participants with PPA. That does sound like a lot. Many of these were case studies, just to put that a little bit in perspective, although there are a growing number of group studies as well. But the majority of studies were looking at lexical retrieval treatments, like the one that I described before, though, they differed in their exact combination of therapy ingredients or maybe how they were looking at their outcomes. A smaller proportion of studies looked at other types of treatments. So spelling and written naming, alternative and augmentative communication, or AAC, functional communication treatments, treatments for speech production and fluency, treatments for spoken discourse, for grammar, among a few others. So really a wide range of approaches. And after we identified the studies, we also rated each one on scales that assessed level of evidence, quality of reporting, risk of bias. We used a predetermined criteria of level of evidence and a score on one of our scales that assessed study quality to determine which studies were more rigorous. And we determined a subset of 45 studies that were of an adequate level of rigor. And so from those higher quality studies, we then summarized treatment outcomes. And when we looked at the treatment outcomes in these higher quality studies, the results were overwhelmingly positive. So all 45 of the higher quality studies showed that there was an improvement in whatever each study was using as their primary outcome measure. 43 studies looked at generalization to either untrained stimuli, untrained environments, untrained skills. Of those, 79% showed a positive result. 38 studies looked at outcomes at one or more time points designated as maintenance or follow-up. Of those, 89.5% reported maintenance over time.
Wow.
And then only 19 studies reported on social validity. So that's measuring whether or not treatment gains made a meaningful change or impact in a person's life. But of those 19 studies, so a smaller subset reporting on that, but of those, 89% reported a positive result. So, yeah.
Wow, overall, that's fantastic. Yeah.
Yeah. So overall, results definitely pointed to the fact that therapy studies showed that speech therapy had positive outcomes for people with PPA. This included all variants of PPA as well. And similar results were found in that previous systematic review by Karthri Goulart. But now the evidence base is much larger, and were able to update the clinical practice recommendations that were put forth in their paper. So lexical retrieval treatment, for example, can now be considered a, quote, clinical guideline, meaning that it is probably an effective treatment to offer to those with PPA who have word finding difficulty. Many of the other treatments in the review can be considered practice options, meaning they are possibly effective. And so I would say there are definitely future directions that our discussion identifies in the paper. For example, we need to understand the process of generalization better, who may be able to generalize skills and who doesn't. And actually, that's an open question for primary effects of the treatment as well. We need to measure social validity more consistently so that we can see when an intervention does have meaningful impacts in a person's life. There's also a need for more research that looks at interventions other than lexical retrieval treatment. So as an example, only a few of the higher quality studies examined AAC or assistive technology, and yet this is one of the things that we often recommend in clinical work. So there's a lot of work yet to be done in PPA treatment research.
Yes. Well, thank you for the work you've done. It's always nice to hear that work is being done, especially considering like 10 years ago, what we didn't know and what we do know now. I was just kind of interested in hearing how you've seen research change for PPA so far in your career. Do you have any examples of kind of like what the next steps might be? Like what might we see in the next 10 years? Or like what do clinicians maybe need to be wondering about or paying attention to in that regard?
Sure, yeah. Lots of great things to go over there for sure. So first, I'll say that for a while there was so much pessimism regarding treatment for this population. And I do think that this pessimism still persists today, though hopefully to a lesser degree than before, especially as we do see more and more research coming out. So people with PPA used to never get referred to see a speech pathologist. I still meet people who have been diagnosed, but who have never been referred to an SLP. I think I'm meeting fewer people for whom that's the case. But I do think that in the past 2 decades, since the research has shown time and time again that treatment can help people in this population, I think the question has shifted now from this sort of very kind of basic question of can treatment be beneficial to something more along the lines of like, okay, so which treatments may be the most beneficial to which profiles or which severity levels? How could we implement life participation approaches for this population? At what point do we bring in multimodal communication or assistive technology? How can we best prepare and support care partners and family members? So I think we're still at the beginning of the process for understanding more specifically these questions and therapy outcomes in general for people with PPA as compared to our evidence base for people with aphasia from stroke. So yeah, I think we have a lot more specific questions forming.
Good. Yeah. And I'm hopeful that it's not just like yes or no for therapy, but it's like, well, yes, let's say yes, but then now let's dig in a level deeper. So that feels hopeful to me.
Yeah, definitely. Definitely. So I think in our own lab, we're definitely moving along with the field to start thinking about kind of some of these future directions that I've mentioned. So my colleague, Gary Robina, who is about to become Dr. Gary Robina, he's heading up a project in which we are now working with people from across the severity spectrum on a multi-component treatment approach that incorporates some of that restitutive work with lexical retrieval treatment, or script training, depending on the variant. Some compensatory work utilizing multimodal communication books or communication devices, and partner-focused work where we educate a close family member or friend about communication strategies, and we facilitate practice using those strategies. And in that study, we do incorporate a life participation interview at the beginning of treatment in order to develop goals and just know what kind of strategies we should think about implementing with the patient. we're seeing good responses to the different components of treatment, and we're very interested to continue to analyze our data and to find out more about how different modes of multimodal communication are helpful to different types of participants.
Wow, sounds awesome.
Yeah, it's really great. Great work. I'm involved in it, but not leading it, but it is great work. Another area of research that is starting to receive more attention is looking at what we can do to maximize response to treatment and stabilize communication for as long as possible. In particular, in thinking about stabilizing communication, in particular, thinking about people who are still in the early stages of the disease. And so to this end, many researchers have been pairing speech-language interventions with neuromodulation techniques, most commonly transcranial direct current stimulation. Again, particularly for those who are still in the early stages of the disease. And so the question here is, can we maximize the benefits of restitutive treatment by facilitating neuroplasticity with these neuromodulation techniques so that people might be able to maintain their communication skills for longer? Kirana Tsapkini's group out of Johns Hopkins did most of the initial work in this area with some very promising results. And so now many other groups are following suit. But it's important to remember that our understanding of TDCS, how to apply it with the most effective placements on the head, the most effective dosages, among other things, is yet to be determined. So there's a lot of work to be done here. For sure.
So with the, I feel like I've been hearing so much about that, the direct cranial or current stimulation. At this point, it's really just at the clinical study, like clinical research phase. It's not yet like someone has to enroll in a study to get that. Am I understanding that correctly?
For the most part, this is true. However, there is a clinical program at NYU. And so I want to be clear that TDCS is not approved by the FDA as a medical treatment. So yes, it's still in the experimental phase. And so for the most part, people do need to be enrolled in a research study to receive that with in conjunction with a therapist in therapy. But yeah, there is the one clinical program I know at NYU.
Okay. Yeah. And then that just might be something in the next decade. We kind of see that shifting or changing, like how it's done as more information comes out.
Yeah. So I'll just plug my own dissertation research right now. Yeah. So in another of our lab studies, which I'm leading up for my dissertation work, we're seeing participants who are mildly impacted, and we're now actually pairing home-based TDCS with lexical retrieval treatment or video implemented script training for aphasia. And so we are doing this because, when you read about the TDCS studies, it is kind of showing that you sort of need this regular, consistent dosage. And it's hard for someone to get into the clinic every day if they're going to have to go to the clinic to receive that consistent daily dosage. So in our lab, we're looking at doing this home-based TDCS with people who have PPA so that it's much more accessible and there's not as many barriers to participating. Yeah.
Awesome. How many years out do you think you are from having data on that then?
Well, we're just in the pilot phase, and we're seeing that with the participants we've seen so far that the home-based TDCS protocol is feasible, it's tolerable, it's been acceptable. So we're not yet at the stage where we can make claims about the effect of TDCS in our own study, but we're definitely excited to continue to explore.
Yeah.
I'm not sure about the number of years.
That's fine. You'll see how it all plays out, right? Good. So we've kind of been circling around the complexities that come with a neurodegenerative diagnosis like primary progressive aphasia. And as a clinical SLP, something that's always been interesting to me in this population is the concept of hope. And especially with diseases that don't really have a cure yet, like PPA. So, since you have been seeing people with PPA for many years now, I just wanted to kind of unpack your thinking about the concept of hope with this population. Can you share a little bit? Do we have a reason to hope? I'd love to hear your thoughts.
Yeah, that's a great question. And, I think thinking about hope for people who are living with an incurable progressive disease is certainly complex. It's not an easy thing to think about. There's not an easy answer. And I think we can't think about hope unless we know what it is we're hoping for. So I feel like people might ask themselves, when they receive a diagnosis, like, is there hope for a cure? That's usually maybe the first question they're asking themselves or their physician. Is there hope that I can do something to prolong the time that I have to, be here meaningfully participating in my life? Is there hope that I'll still be able to do some of the things I love, maybe even as I'm losing the ability to do other things? And all of those questions might have different answers. So for people who are currently diagnosed and currently living with the diseases that cause PPA, there might not be hope for a generally available FDA-approved medical treatment that can cure the disease in their lifetime. And I know that's hard to hear as someone who is living with the disease. As I mentioned earlier, FTD is an underlying pathology for some types of PPA, so most notably SVPPA and NFVPPA. And for FTD, there are no approved medical treatments to treat the disease itself. So there are currently a couple of phase 1 trials researching medications for PPA as a result of FTD. But these are phase 1 trials, meaning that the researchers, they're still testing only the safety and the tolerability of these medications for the respective populations that they're researching. Efficacy is not determined until a phase 2 trial, and then the FDA cannot give approval for new drugs until a larger phase 3 trial has been completed. So even if one of these medications shows promise, it will be quite some time before they are approved for general use. And then for Alzheimer's disease, which is most commonly associated with LVPPA, there is a disease-modifying medication that was approved in January by the FDA. The kind of general name is lecanemab, and it's been shown to lower beta amyloid in the brain, which are those proteins that accumulate, plaques and tangles that accumulate to cause the disease. And so that may slow the decline in Alzheimer's disease. However, this is not considered a cure, and it's currently only thought to be appropriate for those in the early stages of the disease. It's also really important to note that in the context of thinking about PPA, that no studies have yet looked at the effects of this drug specifically for people with PPA due to Alzheimer's. And so for someone living with PPA from Alzheimer's disease, they would need to speak with their neurologist to see if they would be a good candidate for this treatment. Mm-hmm. So while the medication does not provide hope for a cure, it may provide hope for some people to prolong the time that they have to be able to participate meaningfully in their lives. Yeah. And so I think that when many people first receive their diagnosis, the first thing that they naturally wonder about is the potential of medications or other medical treatments to manage or cure their condition. Once they've discussed those options with their neurologist or their other physician, they may wonder if there's anything beyond medical treatment that can help. And it's at this point in the conversation that I think two things may give people hope. First, the potential to incorporate lifestyle changes that may be beneficial for their overall health, including their neurological health. So eating healthily, regularly exercising, getting a healthy amount of sleep. So we've seen in different research studies that these do contribute to overall health, including neurological health. And then also, secondly, the potential to see a speech language pathologist to participate in speech language therapy. So both of these options give the individual with PPA some amount of agency. There are things they can do not maybe to cure the disease, but to improve their situation as much as possible.
Yeah. And it's like a nice mindset for the clinical SLP to remember also, because it's not our role to I mean, we can't cure this, but when we're kind of going out and having more of that quality of life impact mentality, and your review really showed like all of the different ways we can positively impact someone, but at the same time we're not talking about it in a way of like, oh yeah, we're going to cure this. So yeah, thanks so much for sharing that. I wanted to just shift into looking at specifically our clinical practice. And we'll just kind of walk through a few clinical steps. Thinking about the latest research, how we're thinking about PPA, how might our assessment time or practices shift with the PPA population?
Yeah. So, give me one second. Okay. So, yeah, thinking about our assessment practices in line with a person-centered approach, I think we really want to center the person rather than just the impairment when we do our evaluations. So evaluations are where we get the information that we'll use to build our treatment plans. So I think it's really important to use something like the life participation approach, interview tool, to get a sense of the who, what, when, and where of communication for the individual, to get a sense of what their priorities might be. And I would also say that we're learning more and more about the psycho-emotional ramifications for both people living with PPA and their close family members. And so I think that an important part of our assessment that might be missing sometimes is a screener for depression or other psychiatric conditions that may be tied to the process of disease onset and receiving the diagnosis. So if the screener indicates that follow-up is needed, we can start the process of getting the family referred to a clinical psychologist or other mental health professional.
Yeah, very good. How do you see the SLP using their therapy time most effectively given the latest research? I work with a lot of clients with PPA here in Michigan, and oftentimes they've seen other SLPs before they get to me. And it's not uncommon for me to hear things like, well, I did see a speech therapist, but I got discharged because of lack of progress. And that's like how the patient has perceived things, which kind of tells me that maybe the SLP didn't have the correct mindset in dealing with this population. So I wondered if you would just kind of speak to maybe practices of old and then kind of how we're shifting our therapy time now.
Yeah, definitely. So again, I think the field is moving more and more towards person-centered care and life participation approach. So therapy that's tailored to the patient and their goals for how they want to participate in life. Yeah, I think that issue of being discharged due to lack of progress, it does seem like maybe clinicians in that scenario are missing the point that especially with a progressive condition, the goal is not necessarily to make people better. It's to help them achieve goals that will be able to help their life participation, help the way that they're able to communicate. So write goals and designate time for example, education of the patient and family and communication partner training. Those are definitely things that we can help them make progress on, if nothing else, right? And so we're understanding the importance of these components of therapy more and more. And I want to encourage a shift away from quote unquote worksheet therapy, which would be perhaps some of those ways of old. A lot of people that come to us have also participated in speech therapy in the past, and they usually either love their previous experience or they think that it was not useful. And the people that think of it as not very useful often tell us that their clinician may have just given them worksheets in session or for homework or both. and they're just like writing out synonyms for words or doing a word search or something similar. And the patients did not see the relevance of that to their lives. And I have to agree that it doesn't seem relevant. And, there's not really evidence that people doing these worksheets can result in anything, any improvements to their lives. We now have evidence for numerous intervention approaches that can be used in PPA, and none of the evidence points to worksheets as being effective therapy. So our research participants, they really appreciate the work that we do with them to find therapy targets that are relevant to their lives. And so I think that's really important to get buy-in and to have positive outcomes, is to find things that are relevant to their lives.
Love it. And I, of course, agree with you. And it is, to me, the fun of working with the life participation approach and language is you get to find those words and conversations that are unique to the person, and it makes therapy interesting. You're never doing the same thing with two different people. Lisa, you've shared so much with us. So talking maximum impact. If our clinician listeners can take tangible ideas away from our conversation, what would be your top 3 actionable takeaways for them to put into practice?
Sure. Yeah. Well, first and foremost, just that speech therapy is a valuable service that we can offer people with PPA, other progressive disorders. So have confidence in offering your services and letting other providers know that your services are valuable for this population. And thinking about hope for people with this population, just focusing on the education. So talking to patients and their families about their understanding and expectations surrounding the condition, meet them where they're at with active listening and compassion, and help them improve their understanding and expectations and what they can hope for. And then finally, build a treatment plan that centers the person with aphasia and incorporates different types of interventions as appropriate, depending on the person's needs and their profile. Include care partners and families in the treatment plan if possible, and allow your treatment plan to evolve as your patient's needs evolve.
Awesome. Yep. It's really just all about kind of supporting where they're at. Thank you so much. So I was hoping we would have time to do one clinical example. So just like a case example where you can show us or tell us about how this might look in practice. Are you up for that?
Sure. So let's see. I can think of a hypothetical example. So let's say we have a woman who's a reading specialist in a middle school, and then she realizes one day that she has just helped one of her students to phonetically sound out a word, but she realizes she doesn't know what that word means. And then she realizes, maybe she hasn't known what a lot of words mean lately. Anyway, eventually down the road, she's diagnosed with SVPPA, and she's a pretty self-aware person at this point in the course of her disease. So by the time she sees an SLP for evaluation, she's already told her school that she's retiring. She knows that she can't function as highly as before. But her priorities are to be able to communicate with her kids, her grandchildren, and then maybe her wide network of friends. She's quite a sociable person. She has a daughter who's the closest family member, and is the one who's gone with her to all of her doctor's appointments. And her daughter is someone who is a go-getter. She's been researching SVPPA, coming up with all of the answers to questions, things that they can do. And so maybe they get to their SLP evaluation and the daughter, tells the SLP she's heard that they need to get a dedicated AAC device. And that's a big reason that they're there, because that's what they want to do. So the SLP, takes that into consideration, of course, and then asks the patient about, what her experience is with using technological devices such as smartphones. And maybe this person says, well, you know what? I hate technology. I don't like that smartphone at all. I can't even figure out how to text my grandkids back on it. And maybe it's getting more confusing for her too, right? As she's kind of going into this disease. But she says, you know what, I'm willing to do it though. I'm willing to get this AAC device if you can train me to use it. So the SLP has a couple of options there, but maybe thinking about kind of a person-centered approach and thinking about, working with the patient's profile and preferences. Maybe she could suggest, actually, how would you feel about a low-tech communication aid, given that you really hate technology, right? So maybe she shows some example communication book pages where her grandkids' names could be underneath their photos so she can remember them more easily. She could have pages with vocabulary from activities that she does with her friends, amongst some other things, right? So, kind of working with the patient and the daughter to find a solution, something that would be a better fit for the patient's needs, but it's also person-centered and still in line with kind of generally the kind of help that they're wanting or needing.
Very good. That was an awesome case example because we probably all had examples similar to that. So thanks for kind of helping differentiate our thinking through that. I feel like I could talk to you about PPA all day, but we do need to wrap things up. So I wondered if you had any parting thoughts or final words of wisdom that you wanted to leave with the audience.
Yeah. So, thinking about how just hope and maybe how we would talk to clients about this a little bit. I just want to emphasize that listening to the patient and meeting them where they're at is such a huge part in how to have these conversations with people. Some people don't have much of an understanding of what their conditions when they come to you. And so I think listening to their expectations and then kind of helping them to manage expectations is such a huge role for us. And we do that with, first, the most important thing, I think, is those sort of soft skills that we don't always have the best formal training in, but that we certainly can have training in and develop as we go through clinical work is just active listening, compassion, using those sort of techniques to let people know that we're there and we're with them and we're listening.
Thank you so much. This was a really enjoyable discussion. Lisa, thanks for the insight, the clinical takeaways. Thank you so much for the work that you're doing. I really appreciate your lab's work, and I know I've benefited from it in my clinical practice. And thanks for just helping us think about primary progressive aphasia and reasons to hope. Thank you for tuning in to this episode of Speech Scope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Speech Scope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.